an awesome GP.
Hello, GP friends. We are back, and as that new term rolls around, as new registrars enter the practice and supervisors take on new people in their team, I thought it'd be great to go back and have a chat with one of my old colleagues, one of my old comrades, one of my people in the trenches from the Royal Tweed Hospital in our internship. So today I am joined by Dr Nelson Herbert, Tweed Hospital alumni and current GP at Cotton Tree Plaza Medical Centre. Nelson and I were interns together, particularly on our surgical rotation. We were teamed up. And since then, he's built a pretty impressive and diverse career. He spent 3 years doing additional skills in obstetrics and gynecology across Gold Coast Hospital, Robina and Tweed. And he's also done some work as a medical educator, mentoring those future registrars that are now, I'm sure, as your age might indicate, Nelson, are now fully grown GPs. But welcome to the show, Nelson.
Thanks, Chris. Thanks for having me. Yes, as you alluded to, we've known each other for a fairly long time now. I think the other day I was just realizing that we're PGY 12 now. So that's
we're mid-career fellows. Yeah.
Yeah, I don't know. We'll see. We're still babies, apparently. Yeah. So no, I think there's a number of them that have now fellowed as GPs from the college. So I worked as a registrar medical educator and then a medical educator for the college, originally with GP Synergy and then changed to RACGP when they transitioned over. So had a bit of both worlds. But yeah, no, had a couple of dozen odd probably GPs in that time, and there's probably most of them that are out now because I finished working with the college about a year ago. So yeah, no, I've parlayed that into my next parts of supervising registrars in the clinic, doing my external clinical teaching visits because I've got extensive skill from that as a medical educator, and then also taking on some medical students as well. You can't get rid of me just yet from the teaching world.
And it is it is a lot more work, right? But I find it is genuinely worth it most of the time. There are obviously outlier cases that everyone gets, but overall, I think I have a better day if I've done a little bit of teaching, or a better week if I've done a little bit of teaching. How are you finding it just doing clinical style?
Yeah, I think it gives you a different outlook. I went for about a year or so, probably not doing much education with that when I got out of the college. And so that was interesting, but I think I yearned for other stuff. So when I was as an ONG PHO, so an undergraduate registrar in New South Wales, in the hospitals, I did a lot of teaching of a lot of the medical students as well as the interns, things like that. And so that was something that I really cherished, and it gave you a bit of holistic nature to your clinical work, not just, I'm in and I'm just seeing all these patients and that'll be it. Kind of diversified it, which I really liked.
And I think it's one of the great teaching tools is to have your registrar sit in with you, because I'm not sure, I wouldn't say you practice differently, but we know that by observing something, you change it. I do find it's a great way to make sure you're doing fine as a GP.
Yeah, it's kind of like, I mean, at the moment, like I've had a couple of medical students I've got this year, so they're kind of back to back a little bit. But yeah, it's interesting seeing the different type of didactic knowledge that they will bring to the place, and how they will ask you questions about cases and then also think about things differently. So in one instance, as an educator, it's important to absorb what they're doing and how they're getting there, but also look at pathways to say, well, how do you then transition to that next stage? And I think a lot of medical students I've had to kind of talk to and say, like, I don't expect you to be where I'm at with, half a dozen years of GP odd experience under my belt with training and fellowship. That from my point of view, I've done lots of training before that. And like I alluded to, we've been out 12 years now. So, you see a bit more medicine than 3 or 4 years of med school. Yeah, I think it's important to see where people are at which levels, try and bring them up where you feel that their deficiencies are, but also doing it in a way that's constructive. And I think that's a real challenge with a lot of people, because you have to try and find out what works for people. Not one, you can sit there and do a webinar and listen to it and say, this is what we teach everyone. That doesn't work. So it's just about, that can be a good foundational basis. And it's like how people study for exams, that you get a good foundational basis, but you need to find how stuff works for you and for them. And I think that's the challenge of education. And I think that's where you get a good cherishing kind of moment out of it.
And I think what I'm finding, I don't know about you, I get like 8 to 10 emails about cool webinars a week. And I have
a week, a day.
We're both busy. And I'm going to be controversial and say, I don't think we need more webinars. I think come for me, webinar enthusiasts. But it's never been easier for a registrar to look up guidelines or resources or how to approach something. And there's obviously restrictions on AI in teaching utility in registrars, but more and more I'm finding what I'm imparting is the philosophy of general practice and a philosophy to approaching the job rather than the sheer clinical facts. And yeah, they want to check my clinical approach sometimes on odd cases or red flag cases. But more and more I'm finding the utility is in them learning how to be a GP, not the nuts and bolts of it.
Yeah, I think that's the art of GP, and that's a really coiny term, but it's just about, it's the same in any type of specialty. Coming from my time in obstetrics, you can't take the same approach that you would as a GP to kind of get the same results that you want with it as well. So from that point of view, I think there's enough resources out there, and they've blown up in the last few years as well, that the college has quite a number of good exam resources that are on their websites now too, that we definitely try and direct registrars to. And so, because they make the exams, there's a number of paid courses, there's a number of paid webinars, there's didactic, there's non-didactic. It's just, there's so many different types of learning models that I think the benefit that they get more from us as supervisors is actually how we can then help them to become that next level kind of GP and actually grow beyond it. Because I think I said to one of the other registrars or one of the students the other day is that any doctor can sit in a chair and just look at someone, write a script, find a diagnosis, and then kind of go from there. The art from a GP point of view is like how I safety net you, how I then follow up, what's my planning in terms of your next 1 to 4 consults, and how I'm then thinking about the future of your medicine, because you're not someone that I'm just going to discharge back into the community. So that's the difference compared to a bit of hospital kind of care, where I'm not saying see you in 6 months. I'm kind of saying, hey, look, we might not have a planned appointment for the next time we see you, but these are the things that would be good to come back for if you're worried about. And this is a way that I'm going to benefit you if you follow that same train of medicine, basically. You on mute, Chris. Watch out.
What's going on? Sorry, we had planes near us. So I am trying to mute opportunistically. Yeah. Why don't we take some questions from Reddit? I went through the process of just checking on a few places like OzJDocs what the top commented threads were about general practice. And then we might talk about how to survive that first day in a new practice.
Yeah.
Let's put this up. Nope. Okay. So this was one of the first posts if you sort of by relevance and filter it. On OzJDocs, this is GPs, how is your job? And if you scan down through the comments, it is a real hodgepodge of it is exceptional and I love it. And a couple of people are saying that they are really struggling. Other, top ones, we had GP is amazing. That was a great post. This was someone who really appreciated being a GP, not being on call, and called it middle-age nirvana, which I would agree with. But there was also another one from, this was from a year ago, but someone who was feeling dejected as a GP 2 years out. And I think if you Google it, you just get a real spread. You get some people who are absolutely loving life, some people who are a bit middle of the road, and some who feel dejected. And I'm mindful that there is probably a skew. People who don't like it are probably more likely to go and vent and rant. But it is really surprising. We're this weird mix of hope with higher GP numbers than ever, and this mix of people who are feeling forlorn and high numbers of suggested burnout. Do you think GP is great, Nelson? What do you think about general practice as a career?
I came into it sideways. I know, like with yourself, Chris, with my wife, PGY3s, getting into GP, and a number of our friends as well kind of did it. So we've got a bit of a mixture amongst our cohort of friends, actually, where people have come into it. I enjoy it. I don't think I would change where I'm at the moment. I have a good mix of lifestyle as well as work. I don't live to work, I work to live, basically. It's probably a good way to say it. And GP allows me that freedom and flexibility to do that. So I burnt out a bit when I came to the hospital system eventually. And whether it was just part of the roles, the rosters, the organization, the structures, whatever, I loved the medicine, but I just couldn't do that 6 days a week anymore. And we had a child on the way, and I had you guys who were already GPs pretty much by that time. So, and I had another friend who was through that. So I can see the other side of it. So from that point of view, yeah, I think it's got to be right for the person. I think in the past, GP has been this fallback career for some people where it's like, hey, I'll just be a GP if I don't do the specialty that I was aiming for from when I was 10 years old or whatever. So from that point of view, I think it's changed a bit. I think there's a number of people, it's gone through a bit of a transformation that the people that are kind of going towards it more now, and in the last year or two, I would say there's a bit of a lull, are more those that really want to be there rather than those ones that just feel like they've exhausted every other training pathway in the hospital, and they then feel like they're kind of doing nothing else. So I'll just fall back to GP from there. So I think it's a really good career pathway. It's just about finding the right person at the right time of their life, I would say, more than anything else.
Yeah, absolutely. And if you told me like when we were interns that I was going to work 3 days a week, I would not have believed you. But I'm living that 3 days a week life this year, and it is phenomenal. Yeah, I do. It's great. And it's not that I didn't enjoy 5 days a week, but it does require you to do mostly general practice.
Yeah.
And it's hard to fit other stuff in.
It's taxing.
Yeah, it's taxing. And I don't know how, I can't remember the stats about how many GPs are working part-time versus full-time off the top of my head, but I do think we'll probably see increasing part-time trend over the years as more younger generations come through. But we're also training more GPs, so hopefully that'll be offset.
I think there's been a good like uptick. I guess the college puts out numbers and they've been a little bit better in this last year, I guess, from there as well. The training has always been seen as a good training for registrars that are in it. And it's one of those trainings that you're not paying 10 grand a year to do. And it takes 2 years full-time equivalency to be out doing it. Like for a lot of registrars, they're out in the community after those 2 years, non-hospital years, essentially, and they're fellow GPs. And so then they start earning as a contractor. They can control their own days, wages, all of that above it. And really the world is their oyster there, and they're not waiting for 10 years to do it. And I think we tend to put off a lot of else in our lives from medicine just to consider training more than anything else. And so that is only getting longer and longer because of the way that Australia's networks work and the internship, the residency before you kind of get on. And the spots are getting more sparse. So it's harder for people to get onto those. And so I think there's a rational discussion of like, can I apply my skills in a different way to get to a consultant position specialist at that point there in a sooner time and really get enjoyment out of my life? Or would I like to be in a specialty that I only can be in and nothing else? And so that's a really tough situation, and it's a tough discussion. It's very individual. But I think there's a lot of positives that come out of it to leverage your skills that you've got, because not everyone just has one skill that comes into GP. Like they don't just come in and they're like, I'm only general, that's all I do. It's like, no, like in our practice, for example, we've got about 8 or 9 GPs. There's some that have more women's health flair, some that have more skin kind of stuff, some that do more orthopedic stuff, some that do more travel dive stuff. It's all over the place, but everyone has a general basis. And I think that's what the college brings you through to. So that gives a really good grounding. And I think it's how you leverage that to make it your own. And you've got the capacity to do that in GP, which is really lovely.
And I think there's something really to that. I've been thinking a lot about this topic of generalism versus subspecialism a lot lately. And so we've never needed comprehensive generalists more. So we've never needed people who aren't fragmented care providers more. So someone who's doing a lot of general practice and can do most things for a patient. But at the same time, it's when you start getting really good at those subspecialty areas that you're getting a huge amount of value add for your community. So if you're really good at ADHD or skin cancer or women's health, you're adding huge value for your community. And it does tend to be the subspecialty interests that can, if someone wants to give a talk at a conference or someone wants to do a webinar, my opinions on webinars, it's the people who have those subspecialty interests who it's much more common to give a talk. It's rare for a generalist, unless it's maybe a rural generalist, to give a big talk at a conference. And I think it's important to balance that. Like I'm wary with the ADHD stuff I'm doing that I could end up doing a lot more ADHD care than I would like to. I still want to be a comprehensive generalist, but it'll be interesting. To see what happens.
And I think that's an interesting pivot, because it's just our careers are never one thing. I think if you go back to our parents' generation, they get one career, that's it. It's just they go, sure, you'll work for however long and that'll be your job. You might move a bit between companies or something, but you're going to be that. Whereas for us nowadays, even in GP, like the expectation is not necessarily that you're going to be in one clinic for the rest of your life, and then you're not going to be doing one thing for the rest of my life. So I think I agree with the generalist nature. I do think that right now, with shortages of doctors, with an increasing population, with struggle in terms of like cost of living and what GPs can offer, a generalist approach is really valuable in the community. And it doesn't have to be someone that doesn't have subspecialty interests. But I think what I'd hate to see, and I think I had a chat to a colleague the other day, is that going purely into more an American style model where everyone has their own thing that they do and that you go for that person to do that. And I think that's in the news a little bit nowadays from the vaccination debates and people saying you should see your pediatrician and whatever to do that. I think I'd hate to see care. Yeah, I know. I'm not going to go into that. That's another 6 hours of discussion. But I think you'd hate to have those subspecialists be relied upon as the only people doing that part of their care for that part of their life, whereby GPs and generalists have always had that benefit of, I mean, it's the cradle to grave kind of discussion, but it really is. Like, I mean, you'll see people that, and I had a question from a medical student the other day. It's like, oh, do you see the babies that come back after the mums have been pregnant stuff? I said, yeah, I've got a lot of continuity of care from that point. So we may not see them much during their antenatal care in the later stages, but we see them there and then we move on, and vaccinations and mums and dads and, next kids and whatever. So I think generalist has a really important role in our primary healthcare scenario in Australia. And I'd hate to see that fragmented too far, whereby you've got to get a referral to see every different people all the time. And I think we'll just end up being more interns at that point there if we end up being just kind of referring off for every single problem rather than actually dealing with it ourselves.
Well, why don't we move on? Speaking of interns and young, bright-eyed registrars, why don't we move on to give some tips for those registrars starting their new terms? I've got a list here and we can go through whatever you want. If you had to say one thing to a new registrar starting a term, what would it be?
Have a think. Talk to your supervisor. It's probably the first one. I think it's like, don't be afraid to talk to your supervisor. I think there's a little bit of hierarchy that comes when people come from a hospital system, that they're almost afraid to pick up the phone, call people sometimes because of either how others have been treated or how they've got stereotyped. That I think it's different, and that I would say they are there to help you get through. They want you to get through, because if you become a valuable asset and want to stay there, then they've created something in their own mold. So I would say, like, be friendly with your supervisor and be open with them and transparent. That's probably the easiest way to learn more than anything.
And it's a very different relationship. Like, obviously some hospital supervisors are different, but it is a very much a peer-to-peer colleague friendly approach in the vast majority of situations. Let's talk about.
Well, it's one of the only training specialties where you're actually doing the job before you come out.
Yeah,
you're literally like working as it. I know you've got the you're a trainee kind of tag, but you fellow, and the next day you're in the same room, you're doing the same job, you're doing the same medicine, and you can still talk to your colleagues that used to be your supervisors as if they're your colleagues still. So it kind of doesn't change much. That's the beauty of it more than anything else.
And I think the first day of my first term of GP, the first 3 consults were things I had never done before. It was perioral dermatitis, something else, and a driver's license.
Impetigo.
Yeah, something like that.
Yeah. And
I was like,
you get onto impetigo.
All those years of hospital. It's wild. So let's say we had a registrar who does turn up first day, they get a consult, they have no idea what it is. Talking to the supervisor is one option. They can look up therapeutic guidelines. Those are both great fallbacks. I think that'll get you through most initial consultations, and particularly on that first day. Like, your supervisor does not mind being called. They're trying to get a feel for where you're at as well at that stage.
No, and there's almost like when you look at the supervisor training, it's an expectation. So the registrars that we don't hear from are the registrars we worry about, to be honest. And they're the registrars, as you'd understand. So, I mean, and that comes through when I was a medical educator as well for a number of years, that it's the registrars that are then getting flagged and maybe told from either practice managers or supervisors through like our admin staff or to us directly, are those that are not talking, those that you look back and you go, why are your notes not good? Why are you not doing results? Why are you not doing this? And I think it's a good supervisor will try and stay on top of that. But I think, it's the ones we don't hear from are probably more troublesome than anything else.
When you came into general practice as a registrar, what was the thing? I'll give you an example from my end. From my end, the question I ask now that I never really asked when I was a registrar is to basically every patient, how's your stress levels? And it's a surprising high yield question. Whenever someone's coming to me for something, I'll always say, how are your stress levels? Whether it's a rash, whether it's a headache, whatever's coming in the door. Is there any questions that you didn't ask when you were a first-term registrar that you now ask a lot?
I think the openness and the waiting, that's probably the consult art than anything else that you don't do early on. So as much as you were trained in ED and things to be like, hey, what's brought you in today? You still had a nurse that had triaged it. You still had probably some information on file about who this patient was, what their demographics were, what their history roughly was. So you kind of had a bit of a cheat sheet. When you came into GP as a registrar early on, you were trying to almost run with that model and just deal with one thing and be like, okay, what do you come in for today? Great, scripts. Okay, here's scripts. See you later. And then just sit there for half an hour waiting for your next consult. There wasn't get used to that. Whereas now it's kind of, they're walking in the door and I'm closing it and I'm going, what brought you in today? I know from my books that I've already seen it's a vaccination or it's a travel discussion or it's an infectious kind of consult or something else as well. I'm a little bit already clued into as what, and if I know them already, I've known roughly. But I'm always asking that question as they're kind of sitting down, and then I'm sitting down and pretty much listening for 2 minutes. So and then seeing what's going on. And I think that's probably the skill that I gained over time was the general openness question, and then also the listening and just waiting. And as I tell a lot of registrars and a lot of medical students, you don't have to talk much then. Like a lot of your stuff that you actually then bite in on is refinement. You're not actually needing to ask how long, whenever, whatever. Patients will give it to you. And I think that's the thing that takes time in GP to learn because anything can walk through the door. And so that's where you've got to just stay a bit more general and open at the start.
And I think the British actually did a study that said if you just let them sit and listen, it doesn't actually extend the average time of consultation. No. So they've actually proven it in data, and I love that. So you just sit there and listen and they give you a story. And I think that actually is a question I wanted to get to about people coming in with a pretty comprehensive presentation written down from ChatGPT or AI. And they've actually already gone in and said, these are my symptoms, summarize them. What are the key concerns? What should I be asking about? And I actually don't mind that as long as it's guided appropriately. Do you find that in your consult room? Do you get people coming in, like they used to Google, but now it's ChatGPT's giving them a pretty...
I think Dr. Google's moved to Dr GPT is probably one way to see it. I think there's a little bit more that I see of it. It's the easy access more than anything else. And that was the benefit of people Googling it, is that it was just easy to access. That's what ChatGPT does. It talks in a very eloquent way towards you, very friendly kind of manner. So for a lot of people, they really attach to that. And that's something that they can grow on. And especially if they've not had that relationship with any of health professionals before, then they're not going to feel like we're going to talk to them in that similar way or be as encouraging sometimes, which I think is over the top with some of the AI models. But from that point of view, I've seen a couple. They've not been worrisome in my sense. I think patients have almost not owned up to it. They've always just mentioned it being like, oh, I had a look anyway and whatever. And they said these things and I've pretty much said all the right stuff anyway. So it's not like they've brought it up that I'm suddenly saying something bad to them and against what they've looked online. I think it's just more that it's the fingertip access. And that's what people are kind of utilizing and exploring. And I think that's important so people get used to technology. I always like safeguards and I'm always a bit wary about stuff. I mean, I haven't even taken up AI scribing yet with my notes. So it's just like I'm going to test some of that stuff out to see.
You've got to. It's
data security is always a big thing on my head. I think there was the big thing when the PECA originally came out at the start and there was a big data breach in Singapore just before Australia released their personal electronic healthcare records, which is what the PECAs are. And that has refined over time. But I think that was a reason for me to probably just opt out for that time. And I haven't opted back in just yet. So I think I'm just still waiting to make sure that things are all on the ground and working okay. And I've got good streamlined workflows for what I do, so I'm not worried about it. But yeah, I think it's going to be there and we can't reject it. Like it's one of these things that'll be part of our communication tools. And I think for patients, it's important that we integrate it in the right way and that they understand that who the good resource is to come to and where the correct information is. I think that's really important.
And I do want to put up an article I saw about Heidi this week, which I thought was quite great. Oh, yeah. Let's see if I can bring it up. Let's go. So this was an article in the Medical Republic. Heidi is coming for everyone, and why wouldn't they? And it's got Heidi as a monstrous Cthulhu-like octopus sort of swallowing up Epic and best practice in hot docs. And I mean, Heidi, I use Heidi. I didn't find it particularly worse or better than Lyrebird, but they've really gone aggressively with integration, and they rolled out their AI advice screen, or AI for the large language model this week, actually.
For patients or for doctors?
For doctors. So it's got the traditional building block has just been their Scribe tool, which would generate your consult notes, create a mental health care plan, GP care management plan from your conversation. I use it to make a plan, like patient. I just ask it, write patient summary for plan, and I can give them something to go home with. Now they've added a feature. I think they bought another company, but they've added a feature where during the consult it's saying, hey, you're talking about this. These are the details of this. Here are the guidelines on screening cholesterol. Do you have any questions about it? And it'll do essentially what open evidence is doing for that. Yeah,
I don't know if my head can take that. I don't know if my head can take that, Chris. Like I get annoyed when the Gmail app got updated and suddenly has AI overview at the top of every email that I see, and I'm just like, how do I turn this feature off? Because the email is one paragraph. I'm happy to read it. I don't need an AI overview of the dot points of it. So Acrobat at the same time from Adobe does a lot of AI overview that I'm constantly clicking boxes to get rid of it. So I think there's a benefit to it. I think the danger in some of it has been, in my mind anyway, the MBS item suggestion. And I think that is a potential pitfall for a lot of GPs that are not thinking about what those suggestions are based on, because it will suggest a care plan to basically everyone, or a chronic condition management plan that they are now. So you have to be careful that you're doing the right thing under Medicare's rules, and that you're treating patients appropriately at the same time, and whether that's actually warranted. I think those ones are a little bit risque. I think that I can only get so many suggestions before my brain overloads, I think, in a consult. And when you've got 10 to 15 minutes to go from undifferentiated to essentially differentials, exam plan, and then kind of notes, I don't know if I can take any more throwing on top of it, because I think I'll just be so overwhelmed considering what other options are there. And everyone's brain works differently, but yeah, I think I've got the resource that I will flick up, and I've got the data in my head that I can remember on things. And sometimes I don't remember stuff, but I know where to look it up. So I think it'll be useful, but I'd hate to have new trainees rely on that as a way to learn GP and medicine in that nature. I think it'd be important that we're just cautious with those kind of early trainees coming into it, more than those that have been out for, like, we have a dozen years or so.
And they do need that skills training. We don't want skills attrition. I guess there is a real risk of skills attrition from people over relying on the technology. I think one final question that came out of what you were just saying is probably worth doing as our last question, which is the undifferentiated patient, and what you do with the undifferentiated patient. Because that's very common as a problem. That's a lot of what I get called about as a supervisor. That and the skin rash. I've sometimes when they first turn up, they pigeonhole me as the skin guy, and they don't realize I do everything else. But,
at least he's not the ADHD guy yet. That'll come.
That'll come, I'm sure. But yeah, what do you do with the undifferentiated patient? And there's obviously a nuanced, many factors involved. But what do you do with the undifferentiated patient in general if you're advising a new registrar?
I mean, so the differences between what I would do and I guess advising a registrar, so they're two different scenarios. So from my point of view, I think it's important that your history taking is still broad enough that you're finding out things, and you need to read body cues with it. That's the biggest thing that I think I find in GP that I probably didn't read early on. I use tissues a lot in mine. There's a lot of tears that happen at times because I see a demographic from single-digit kids to 101-year-old, actually, I've got as well. But across all different, like, every gender, every other means. So I'm not just someone who sees just 80-year-olds and does chronic medicine. So there's often cues that I'll see in either antenatal mums or in young fathers or something else that I'll be like, so, is there anything else going on? Is there other things happening? So you can get a history of the presenting stuff that they bring in, but I think prodding around that is important, and having those right and open, diverse questions to kind of say, hey, is there anything else that could be affecting this? Are there other ways, like, how's your life going? How's your sleep going? How's your diet going? All those other things on top that they may not have correlated as much. And it's like your questions of like, how stressed is this for you? Something like that can really kind of leverage that and say, is this affecting anything else? Or are there other things to do? And I think bestowing that upon a registrar is important, but then giving them the open space so that they can then come up with their own kind of surgical sieves and agendas to ask questions for. I think that's an important supervisor trait, that you don't want to turn up and do the consult for them. I think if you do, then you may as well be there and not them. And so what's the point? They need to learn, they need to grow. They're not doing anything unsafe, but at the same time, you need to give them those foundational blocks so they can go, okay, if this is here and it doesn't seem right and they seem a bit jittery and everything that's going on, it's like, I need to kind of like wonder whether that's affecting this on how I ask about it, while also keeping in place what your timing are. Because the last thing you want to do is just go, 40-minute consults every day when you're booked for 15s. I think from that point of view, it's your safety netting and it's getting people back. And sometimes it takes that you're not getting an answer in a consult or two. Like it might take you a couple to get a proper diagnosis of what's going on, or it might even take more of a specialist to find that out further beyond your field. So I think it's the confidence that you have to say, hey, let's do these tests, let's do this test. Look, I'm going to book you back in on Tuesday. We'll chat about it then because I'll have the results back. If this happens like this, then you can go to ED. These are the other options you've got after hours. However, if you feel that, then give us a call and I'll try and fit you in, those kind of things. So I think it's about how we talk to patients and integrate within their lives and make that work, gets more appreciation from them and gets you to the answer at the end of the day. I think if we stand back off and go, hey, it's just us and we're taking a paternalistic view of how we just diagnose and what we define you've got, then I think we miss the trees for the forest kind of thing at the end of the day.
Would it surprise you to know the British have studied using the phrase, is there anything else versus is there something else? And have found that one yields significantly higher response times?
Yeah, I know. I think I've probably got a problem where at the end of consults, I probably ask, is there anything else when I really shouldn't? And I'm already at 14 minutes. So that's
I think that's reasonable. And I teach registrars,
but it's just about time.
Better you do treat a couple of issues really well rather than giving a half treated, half worked up answer to a problem sometimes.
Yeah. And I think people feel that you're talking to them then. You're not talking to just their condition or whatever they've come in with. I think the more that we can humanize people as they come into the clinic, the more they want to come back, the more they actually feel like they're heard. And I think that's what endears them to your type of medicine. Everyone does it slightly differently, but you will get a following in GP that is the people that appreciate what you do, how you talk to them, how you respect them, and how you listen to them. And those are the ones that will keep coming back because they appreciate what you say and they'll bring their relatives to see you and they'll do other things. So, that's the following you'll get from just being a human. You don't need to be a robot in GP. And I think that's people that miss the boat of what medicine is. And I think there's a real art to it that can be really kind of found and enjoyed.
You don't need to be a robot. You just need to be a human. That is a fantastic line to leave us on, Nelson. I think... did you ever call me Tim's bot? Was that my high school friends, or was that something that happened at?
No, I never called you that. It's Tim. Okay. Tim's something, but it wasn't. There was nothing derogatory. I don't think of that. It was like Tim's chat was probably the worst that we had of that.
So we've had a delightful chat. We still haven't gotten to the bottom of who set up me and my wife, you or your wife.
It's gonna be my wife. She's never gonna live that down, so it's fine. I'm not gonna chase that.
So we'll head off. I believe my daughter's probably going to wake up in the next 10 to 20 minutes. But you have a lovely day. It has been excellent picking your brains on the philosophy of general practice and how to be a first-term registrar. For those who are keen to hear more of what I'm doing, the GP show has just dropped a podcast with me running them through a game of Dungeons and Dragons as Dungeon Master. So if you're someone interested in that, go over to the GP show and have a listen to their latest episode. Other than that, I will say goodbye to you, Nelson, and you have a great day.
No worries at all. Thanks, Chris.
Roll the dice, see the fate. Monsters lurking at the gate. Heroes rise in the night. Doctors wielding magic.